Welcome everybody. Thank you for joining. This is an SPCR funded study. That's the workshop. That's the School for Primary Care Research. And I'm Carolyn Graham. I'm going to chair today's meeting. And as I say, thank you everybody for joining. I've got a few thank yous and house rules and things to go through first. So first of all, this workshop's going to be recorded. So if you feel that you don't want to be recorded, and I think we did advise, then please keep your camera off. But hopefully everybody will be okay with that because they did have some advanced warning. I need to mention and say great thanks to Michelle and to Deborah from the School of Medicine at Keele, because they have the organisational skills that I lack and have managed to put this together. So thank you. I also want to mention Ian Maidment from Aston, David Kessler from Bristol and Tom Kingston from Keele, who put together the application to the School for Primary Care Research for this workshop. There is a history of this workshop. So we first of all got funding to do a workshop on drugs and mental health. And we had 80 people registering, and we felt that an online workshop with 80 people just would not work. So we decided that we would go back to SPCR and say, actually, we'd like to run 3 workshops on different aspects of drugs and mental health. So today's workshop on antipsychotics, we're then going to run a workshop on bipolar, which David is going to organise and chair, and then a session on reducing antidepressants. These are going to be later in the spring, and we will notify folks about these, although I think you've heard already. So the aims of the SPCR workshops really are to bring people together across academia, research, education, clinical practice and policy, to develop collaborations and to develop networks, and hopefully to develop new research collaborations, funding applications, but also think about improving policy and influencing practice. So I'm going to try now and advance my slide, which is, as I say, the technology is often evades me. So this is the timetable, which I hope you're expecting. We'll try and stick to this, and I definitely will try and finish on time. What I thought we would do is actually do some introductions, and I know it's always difficult when it's online and we can't see each other, but if I can go down the list that I've got for people just to say briefly who they are, I think that would be helpful. We're then going to do some breakout rooms where people can get to know each other a little bit better, but I think it would be nice just for people to say something at the start. So I'm just going to go down the list I've got in no particular order, and if I miss anybody out, I apologise, and you'll have to shout up. So is it Aid DK? If you just unmute and say hello, that would be great.
Hi all, my name is Ada DK, Senior Clinical Pharmacist, NHS 5 in Scotland.
Fantastic, thank you. And Tinola Adepitian, and I'm really sorry about the pronunciation there. Tiniola? Okay, maybe not here. Gufran Arkoub.
Hi all, I'm Gufran Arkoub, and I'm an overseas pharmacist who's working on converting my degree in the UK, and I'm working for Central Northwest London at the moment as a senior medical officer.
Fantastic, thank you.
Thank you.
Xiao Chin.
Hello. Xiao Chin. Ready? Hi, well, my friends call me Chinny. My colleagues call me Chinny. I'm a mental health pharmacist at Livewell in Plymouth.
Fantastic, thank you. Clara Ranera.
Hello, my name is Clara Ranera, and I work as a system and mental and physical health pharmacist for Cambridgeshire and Peterborough CCG.
Fantastic. So it's great that we've got all these pharmacists on board. So School for Primary Care Research will be really pleased. Yvette Cramp.
Hello, I'm a pharmacy technician and I work in MHSOP in a mental health hospital.
Hi, thanks Yvette. Matthew Croft.
Hi, I'm a pharmacist working in secondary care, but with community mental health teams in Yorkshire.
Fab, thanks. David Kessler.
Hi, I'm David Kessler. I'm a professor of primary care at Bristol University, and I used to be a psychiatrist a long time ago.
David Shires.
David, you are mute.
David.
Sorry. Hi, I'm David Shires. I'm a former GP and a honorary research fellow at Keele. My daughter's had severe mental illness for 25 years, and perspective of that on antipsychotics is that as a dad and a carer.
Thanks, and we're going to hear from David shortly. Deborah Thomas, do you want to introduce yourself?
Sure.
Put a face to the name.
Good morning, I'm Debbie Thomas. I work in the School of Medicine at Keele University.
Madeline Foote.
Hi, I'm Maddie. I'm a pharmacist, mental health pharmacist. I work in secondary care in the community teams in Scarborough, Whitby and Rydale.
Fantastic. Stefan Gogwas.
Hi there. My name is Stefan, as you said before, and I'm a secondary mental health pharmacist. I work in community mental health teams in Lincolnshire.
Himabindu Gundapudi.
Hi, I'm Bindu. I'm a CCG pharmacist. I work in GP practices.
Joanna. Oh, sorry.
Yeah, that's it. Thank you.
Joanna Peacock.
Hi, I'm Jo. I'm the lead mental health pharmacist in an Iron Bevan Health Board in South Wales.
Thank you. Richard Lewis.
I'm Richard Lewis, pharmacy technician. I'm working as the Pharmacy Operational Services Manager for the Mental Health Trust for Lincolnshire.
Great, thank you. Jodie Linfoot.
Hiya, my name's Jodie. I'm a pharmacy technician. I work in community services in the Yorkshire area.
Great, thank you. Maria Marin Barrio.
Hello. Hi. Hi. My name is Maria. I'm working in the mental hospital in Rosebery Park, and also I work with Yvette in the adults mental health, and I'm a pharmacy technician.
Hello. Michelle. Hello. Michelle Press.
Hi, I'm Michelle Press. I too work within the School of Medicine at Keele University.
And Natasha Moeldeen.
Hi, I'm Natasha Mohi-Eldeen. I'm a mental health pharmacist working for CNWL, currently working with community mental health teams in Westminster.
That's great, thanks. Saeed Farouk.
Hi, I'm Saeed Farouk. I'm Professor of Psychiatry and Community Mental Health at Keele and Consultant Psychiatrist at Midland Partnership NHS Trust.
Okay, Sarah Guest. So Sarah, we don't have your second name.
Oh, apologies. My name's Sarah. My name's Sarah McCartney. I'm a mental health pharmacist currently working in Central and Northwest London, in both community mental health teams and some inpatient wards as well.
Fantastic. Meena Sethi.
Hello, I'm Meena Sethi. I'm the Borough Lead Pharmacist for Brenton Harrow for CNWL. And it's lovely to meet you all.
Great to have you here. Jennifer Southern.
Hi, I'm Jennifer Southern. I'm a pharmacist for the CMHTs in Cheshire, and I, during lockdown, finished my MSc with Ian Maidment at Aston. So it was about clozapine, so hence I'm quite interested in this presentation.
Fantastic, thank you. Tom Kingston.
Yeah, Tom Kingston, lecturer in mental health and wellbeing at Keele University.
And Vera Logan.
Hi, I'm Vera. I'm a nursing lecturer in Swansea University.
Hello. Has anybody not said hello? So somebody's got a hand up. So do shout out. Dimple Oza.
Hello, my name's Dimple Over. I work with Stefan and Richard in Lincolnshire. I'm a specialist mental health pharmacist working with the community mental health team.
Fantastic, thank you. So I think everybody should have said hello, so thank you very much. So we're going to move on to a brief presentation by Saeed Farouk, who's introduced himself. He's going to talk about metabolic side effects of antipsychotics. I'm going to try and unshare my screen, Saeed, and you can put your slides up.
Yeah, I'm just trying to. Yes, you have to. Browse my computer. It will take a bit of time. Sorry. Okay. I think you should be able to see it soon.
Can't see anything yet.
Yeah, I think it's just.
Is it loading?
On my slide, the cursor is it's uploading. Hopefully something should be coming up. Yeah.
Yep.
Is it?
It is.
Okay. Thank you. Good. All right. So what I'm going to talk is just quickly about the side effects of antipsychotics, how big is this problem, and what opportunities it provides for collaboration and research. And because it's such a huge problem, I'm just going to focus on the physical health side of the antipsychotic side effects. And what I'm going to highlight is that the antipsychotics differ substantially in their side effects, although efficacy-wise there are not much differences. And that provides us opportunities for research and collaboration, identifying the effective ways of managing side effects, and then about also improving, whether we can switch from one antipsychotic or another. The main thing I would like to stress is that the side effects of antipsychotics is not only a physical health problem, which of course is a very big public health problem. That is a key problem in the treatment of schizophrenia. Other than that it interferes with the adherence of the managed treatment. And that, of course, when there's poor adherence, that leads to a lot of other problems as well. So I think I know that a majority of people who are here are pharmacists, and they must have very good knowledge of antipsychotics and the drugs, perhaps better than me. But what it's often very well known is that the weight gain, insulin resistance, and elevation of blood glucose and total LDL is the main problem associated with most antipsychotics, and it's a very well established. And that has led to a very high prevalence of metabolic syndrome in those people who are taking the antipsychotics. What is not often realized that the problem is predominantly, I would say, in those people who are taking what we call the high-risk antipsychotics. And those high-risk antipsychotics are the olanzapine, risperidone, and the quetiapine. Although the others are not less, but compared to these, these are lesser culprits. And what is not often realized is that the weight gain and the antipsychotic side effects not only lead to the physical health problems, it also lead to poor quality of life, and also leads to poor concordance with the treatment, and then relapses and admissions. And there are 2 systematic reviews, at least, which show that the metabolic side effects can severely impair the treatment adherence, which is a very big issue in the clinical practice in psychiatry. The antipsychotics have relatively small differences in the efficacy, but quite significant differences in the side effects, and that's now well known. There are two large meta-analyses which I have given the references in the slides. By the way, slides will be available and all the references are at the end. There are two big meta-analyses, one comprising, I think, about 48,000 plus patient population in 212 randomized controlled trials. And other than the clozapine is, of course, a different, a different drug because it's only used in treatment-resistant schizophrenia. Other than the clozapine, the efficacy differences between the antipsychotics we commonly use in clinical practice are relatively small. But there are big differences in the side effects. And at that point also to realize is that, which I'm not going to discuss today, it's not only the metabolic side effects, there are other side effects, like, for example, akathisia, Parkinsonism, agitation. They also differ widely across different antipsychotics. So these meta-analyses show that olanzapine, risperidone, and quetiapine cause the highest rates of weight gain and metabolic abnormalities, whereas aripiprazole, lurasidone have far less impact on weight and metabolic parameters. One newly introduced antipsychotic in UK, cariprazine, it's relatively new. That also has, I wouldn't say it's weight neutral, but it causes much less weight gain. So just to put it simply, the older generation, second generation antipsychotics, olanzapine, risperidone, quetiapine, which led the second generation antipsychotics, are the most commonly cause these metabolic side effects, while the newer generation, second generation antipsychotics, that is the aripiprazole, lurasidone, and cariprazine, they cause far less metabolic problems. The problem is that it's not only, the problem is that the second, these antipsychotics, which cause a lot of weight gain, they are still very predominantly used. So what can be done as far as research and the clinical practice is concerned? Of course, regular monitoring, reviewing, and then switching. I'll talk about that a bit briefly. Education and training, recording appropriate selection of antipsychotics when starting the treatment, and appropriate use of interventions for preventing weight gain from the outset. That is the lifestyle interventions. The problem with the last intervention, and I don't have the time to talk about it, but just put briefly, there are two large randomized controlled trials conducted in UK recently, published, I think one in Lancet Psychiatry and one other, and both of them showed that the lifestyle interventions didn't make much difference over a year. And I think the problem is not to do with the intervention itself. Its problem is with the population where these interventions are implemented. If you think that this is people with schizophrenia who lack motivation, who have negative symptoms, implementing the lifestyle intervention is very challenging. So this is the real challenge for clinical practice as well as for research. I think you're all aware, and I think David shares and his colleagues have been talking about screening and intervening, screening for the antipsychotic side effects for more than a decade now. The problem is that there's a lot of screening going on, but there are very few interventions which can be implemented in routine clinical practice. And I would like to stress in routine clinical practice, because in research there are a lot of randomized controlled trials, but when they come in the implementation in the clinical practice, there's very little which can be done. So this is the UK Public Health England findings, and so it shows that gap in the life expectancy has not actually decreased. So the people with schizophrenia have reduced life expectancy. That's a very well-known finding. That's finding we knew from early 90s. But the problem is that instead of decreasing the gap, there's not much. The gap is actually widening. And the reason I feel, one of the reasons, there are many reasons, but one of the reasons that the gap is not reducing is that the message that has not gone beyond screening. We are doing a lot of screening, but as far as the interventions is concerned, there's very little in terms of interventions. And one big issue is about using the antipsychotics, which we call high-risk antipsychotics. We showed that about 60 to 70% of people who are receiving antipsychotics at the moment are still using the high-risk antipsychotics. So what we can do, the problem is we cannot stop antipsychotics because there's plenty of literature that stopping the antipsychotic even 2 or 5 years down the road is associated with high risk of relapse. So one big issue is whether we can switch the antipsychotics from the higher risk antipsychotics to the lower risk antipsychotics, and we have been working on this for almost 2 years now. We published this qualitative study. We also, in which we did with the mental health professionals to elicit their views on switching antipsychotics. We also did a clinical audit, which I'm not going to discuss here, but briefly speaking, what it shows, what our qualitative studies as well as our clinical audit show is that there's a big need for educating the antipsychotic to use and switching the antipsychotic. To put it simply, no one wants to rock the boat and the boats because switching antipsychotics is really and it's not only to do with the clinician, it's also to do with the services. In this study, people told us that while you are sitting in a busy clinical outpatients with a lot of patients to see, you very rarely think of switching because that entails quite a lot of issues, talking, involving people, taking them through this switching. So that is really considered. So with this in view, we are developing an educational intervention for switching antipsychotics. The plan is that we will develop an intervention for clinicians to consider and review the antipsychotics, the high-risk antipsychotics, that is olanzapine, risperidone, quetiapine, and then build that intervention within the healthcare records so that the people have easy access to the resources for switching antipsychotics, and then can discuss it with the patients using the shared decision making. So it's a lot of work, and you will, what I can say at this stage is we are working on this, and we just had a research grant for that, but we cannot talk about it more than this at the moment because the contacts and the whole process is going through. So what I can say is just watch this space. Other than the switching, there are also problems about shared decision making. So this whole area of monitoring antipsychotic, discussing antipsychotics, and switching antipsychotics, and starting the optimum antipsychotic at the first contact. This is a whole big area for research and collaboration. So thank you very much. That's what I have to say.
Thank you very much, Saeed. Has anybody got any questions for Saeed while I just try and upload the PowerPoint again? People want to shout out? Okay.
There's a hand up.
There's a hand up.
Yeah.
Renera.
Yes, that's for me. Thanks very much for the presentation. That was very helpful. I'm just wondering, you mentioned about the guidelines and the switching, but it has not been mentioned about recovery or deep prescribing or reviewing when actually, it's something, it seems that if you are initiating an antipsychotic, it's something that you stay for life, because it's a lot also guidelines for prescribing and switching, but it seems to be no guidance at all for how to deprescribe, and also the GPs and healthcare assistants that are doing the monitoring. They have, as you said, they're completely out of the scope to review if that prescription is still suitable. And I feel that's it's like no mention. It's just, and I as well, another thing is you might be initiated with antipsychotics for an episode of psychosis, but how do you know you're still relevant? How do you know it's because it was a vitamin B12 deficiency, for example, or something else going on? And I don't know the diagnosis, because it can be quite, maybe it's not objective. So just I just would like to raise that issue. And as you know, with the recent overprescribing review, we know the 10% of all prescriptions that are not needed. So just to put out there. Thank you.
Does anybody want to respond to that, Saeed?
No, what I was saying is that is really, that is an important issue, and that could be, yes, that could be an area for the research. Stopping and deprescribing antipsychotics is not as simple as stopping and deprescribing the antidepressants. It's a completely different ballgame, and I would say, yes, I would say there could be people who are not perhaps appropriately on the antipsychotic, or perhaps not on the appropriate antipsychotic. So that is the area which is wide open for research.
And I think as a GP, I just want to echo Clara's point that too often people are started on antipsychotic in specialist care, discharged to primary care, and to be quite honest, GPs are really worried about interfering with the medication regime and reducing without specialist care support. So I think perhaps it's something that we could come back to in the breakout rooms when we've got the opportunity for discussion. And defining what the sort of research priorities might be. Somebody's waving a hand.
Yes, yes, me. Sorry, just to add, also,
Clara.
I forgot to mention that in the recent audit I undertook in our region, I found that also it's another thing which is not mentioned, which is the amount of thousands of patients now on antipsychotics because of the personality disorder. So again, nobody wants to touch that, but I think it's quite outrageous, these patients that they don't have any support.
Yeah.
Absolutely agree. Yeah, because often with the UPD, it's the lack of other services that are available, so a lack of appropriate CBT. David, do you want to say something to this? You appeared in either David Kessler or David Shires. You both have appeared.
Yeah, well, I certainly do. I mean, thanks again for that talk, which was very good, I thought. I think just in response to the last comment, NICE guidance and British Association for Psychopharmacology is very clear that you do not prescribe antipsychotics for personality difficulties or disorders, and yet it goes on. And I think there's lots of other areas where, there's a couple of other areas, should I say, where antipsychotics are being prescribed increasingly. And one is anxiety, surprisingly, and the other is treatment-resistant depression. And I'm sure we should, as those of us who are working in the community, need to be thinking and talking about those developments as well. I think one other comment, I think the Maudsley prescribing guidelines may contain advice about switching. I'm just looking while we're talking, so I'll come back to you on that. But brilliant. Thanks.
Thank you. David Shires, did you want to say something?
Prescribing antipsychotics off-label is very difficult to justify. Is it happening in Britain at the moment? I don't know.
Sorry, yes,
yes,
is the answer. Yes, is the answer. Very much so. We've done. Are you talking about? Sorry, David. Are you talking about personality disorder or anxiety?
Well, I mean, a range of conditions where you're effectively prescribing off-label. So anxiety, poor sleep, behavioural disturbances. I mean,
yeah, I can quote you chapter and verse on that, and we've done some work on that. But yes, it's the answer. And also there are currently at least 2 trials going on, one coming to completion and one about to start, about adding in antipsychotics for treatment resistance.
Yeah. I think there's quite a lot of quetiapine prescribed in anxiety disorders.
Exactly.
Yeah.
Quetiapine is the drug of choice in this situation. As you pointed out quite rightly, it's metabolically adverse.
Exactly. And to be honest, what I'm afraid of, I didn't touch it here because our research is only focused on severe mental illness. Considering the prevalence of anxiety and depression, the problem is much higher over there compared with the severe mental illness. And it would be a very good study just to look at the extent and what it is causing. I'm sure it must be bigger problem than the SMI because the prevalence is so high.
I just want to plug, we've got an SPCR funded workshop on anxiety at the end of March, which I think should be on the SPCR website. So and David, you're involved in that, aren't you? David Kessler and myself, led by Katrina Turner at Bristol. So if you're interested in that, do have a look on the SPCR website because we will be focusing on this. I'm going to move on because, as usual, I'm chairing badly and running behind. Can you see the graph about the widening mortality gap? Will somebody say yes or no? Yeah, okay. So this is really just summarising what Saeed said, that people with severe and enduring mental health problems still die 20 to 25 years sooner than people without those conditions. So now David and I are going to, well, David predominantly, is going to talk about being fattened and flattened. So David.
You're going to remind me what to say, aren't you, Carolyn?
So you're going to tell us a bit about Mary, and this is to just put her in context within your family.
Okay, so we live in Leek in North Staffordshire. I was a GP there for many years. Mary's now in her mid-40s. It's in a residential care home just a few miles away with 4 other ladies who predominantly have diagnoses of learning disability. And Mary was given a diagnosis of schizophrenia just over 25 years ago. So we're talking the mid-90s. And if you could just go on to the first slide, Carolyn. Just to prove I was young once. I can't hear you. I think you're on mute, Carolyn.
So you should be able to see the slide with Mary in the middle and you at the top right.
No.
Oh no, is it not moving? Oh goodness.
Okay, I'll keep talking.
Try that.
No.
There we go, I'll have to do it, yeah.
That's it.
Is that it?
Yeah, that's great. So Mary, one of 3 children, she's the eldest with brothers Rob and Ed, twins. And this is just to prove that I was actually young once. And so Mary was very fit and active. She went to normal school. She had a difficult birth. She began to struggle with some of the schooling and language as she came into the early teens, and then became quite depressed, and then rapidly developed a very sort of deterioration with paranoia and suspicion and all sorts of odd perceptions over the space of probably about 6 weeks. Initially, Anne's a nurse and I'm as a GP, initially we thought, well, she's very depressed, perhaps she's maybe being bullied, but things were escalating really quickly. She had a visit from a psychiatrist to home, so she'd be the age of 16 at this stage, and the psychiatrist said, I think your daughter's suffering from schizophrenia. And that started a year of CAM service where Mary was at home, and we really struggled. We sort of battened down the hatches. Mary tried various antipsychotic medicines. So we're talking about the mid-90s and just the beginnings of the sort of second generation drugs. Have you got the next slide? So Mary went through a series of services and never really responded to any medicines. She had mood stabilizers, she had, say, a host of different antipsychotics, went through into crisis and went into an adult ward for 6 months, which was awful. So Mary had really gone from a service. The psychiatrist admitted that the CAM service wasn't really up to dealing with psychosis. If we could hang on to the adult service, it would be more appropriate. So that was 12 months. And then when Mary went into the adult ward, this was a sort of chaotic environment, and people were generally, 10, 15, 20 years older than Mary. So she'd gone from a maybe a service that didn't do psychosis. She'd wanted a service that did psychosis but didn't do young people. So it was clearly a big gap. And she deteriorated in that setting and was eventually moved to the so-called rehabilitation unit at the local asylum, which is still engraved in my memory, really. And it's now a very smart housing estate in the area we live in. But at that time, it was a very grim institution, hidden away. And Mary went on to a small unit for rehab, which was essentially, she had an 8-bedded dormitory without any curtains or carpets. So we were pretty much in despair. Mary had completely disconnected from real life. She was drugged up, hence the flattened. She'd gained a lot of weight. And I think the saddest thing really was that she was very isolated. She was forgotten by her friends. She really struggled. She didn't do anything. She sat around watching TV. She was given extra helpings of puddings because the staff felt sorry for her. The corridors were full of elderly men smoking. Thankfully, Mary never did smoke, but the culture was one of smoking. And there was me as a GP giving advice on cardiovascular risk, etc., to a general population that were probably 20 years, 30 years older than Mary. And Mary was being exposed to exactly the same risks, but she was only 19, 20. And the fattened, I'll come a little bit further onto that. Mary's weight shot up. So we were in despair. As a new psychiatrist emerged to take over the unit called Fiona. In fact, yeah, Fiona said, I think you should complain about the service I'm offering your daughter. One. And the second point was that there's this drug called clozapine, and it's been reintroduced recently. And she explained the background to clozapine. And this was very much of an informed decision that we were involved in as family about the risks from the drug and the particularly the bone marrow risks. But Mary didn't seem to have much to lose. Within 3 or 4 weeks of starting clozapine, we began to get glimpses of the old Mary coming back. It was extraordinary. Right drug, wrong place. So it was the right drug, but the wrong place. So Mary was on 900 milligrams of clozapine at one point. And so she was flattened, fattened, and forgotten. So I think, that's just to give you a picture. The complaint was intriguing because 2 years after the complaint, we fought to get Mary out of this institution. And she went into a commissioned young person's unit in the community where we saw real rehabilitation. It was a fantastic place. So right drug, right place by this stage. And tiny incremental improvements, almost imperceptible, and we learned how to celebrate things. And she gradually began to restore to the old Mary, who was a very cheerful and very, very happy woman. Mary hated being fat. She absolutely, it was yet another dimension really to this. And she never stopped taking her meds, but she really hated this sort of body image change. She's very proud of how she looks. She can shop. She still can shop for England. So I think that's enough background of our experience with this sort of very early phase. So the striking thing was the amazingly rapid growth of weight increase, but also the environment was appalling.
Yeah, thanks, David. So I'm going to put the next slide up, which is about weight gain, to illustrate that it's people in their first episode of psychosis that's where they develop the weight gain, as you've illustrated.
This is Mary's trajectory. This actually was the trajectory, but this is a re-evaluation of a lot of RCTs, and actually this, it really showed this sort of. It's within weeks, isn't it? We've got a very expert audience here, but this happens within weeks. And often the advice is, well, if you could just hang on, we just need to get the psychosis settled, and we'll sort the rest of it out later. Well, it's done
too late.
Pretty fast, yeah.
I'm going to go back to that slide about Mary. Do you want to mention the toothbrush? Because we're going to come back to this at the end very briefly, just plugging another piece of work that we're doing.
Just basically, Mary's experience in another care home, as Mary went through the care system, she went into what became really not a very good care home, and this was the state of a toothbrush. And you know, we'd pull our hair out really, because we'd go in, and Mary of course has high rates of, you know, of dental problems potentially, 2 or 3 times the rate of total dental of tooth loss, high rates of caries, and the key is prevention. And now she's in a care home where the care is superb. She sees a special care dentist, I think it's twice a year. She has fluoride varnish on it. It's completely different. So it's a really important area. And of course, Mary now has 4 conditions and takes 11 pills, and she's only in the mid-40s. And it's difficult. I mean, the treatment burden and the sort of going from one service to another is a real challenge. So imagine the challenge of dental services on top of physical health services, on top of psychiatric services. So, you know, but these are problems being stored up for the future. I mean, this slide, I guess when we sort of started our pathway, this really wasn't understood. So this is emerging evidence, which just confirms, you know, Saeed's touched on this, it just confirms that this group are heading on a pathway towards high cardiovascular risk and risk of diabetes, and many other conditions too, COPD, you know, respiratory disease from smoking. So there are a whole stack of things, and the problem is it's not dying early, it's having lots of different disorders at the same time. And the challenges of multiple morbidities in terms of, you know, treatment burden, investigation burden, navigating a system which I'm afraid is still quite siloed, is really complex. So, yeah.
And that's the something from your recent editorial.
Yeah. I mean, I suppose the point about this, keeping the body in mind, and this has just come out a few weeks ago, we've gathered about 8 really interesting articles on frontiers in endocrinology, which is good, isn't it? So we're going to different frontiers too. And this really matters to families like mine. You know, things have moved on. So 25 years on, there was no research being done like this 25 years ago. So there's a collection of really interesting articles here. There's something about the off-label use of antipsychotics, actually. There's a good article there. There's some very encouraging evidence of if you get in early. Worcestershire, Joe Smith's service called SHAPE, a good clinical early intervention service, have worked very hard at keeping the body in mind early on. So Joe and her team have reported in this series of articles about the impact they're having by getting in really early. Saeed mentioned the large RCT on interventions, which was stepwise. And the problem with stepwise, I was involved in that. The problem with stepwise is it couldn't recruit people with first episode illness. And if you don't get in the first few weeks, it's late. And so these people have very established illness, and it's a completely different challenge. But we are seeing small reports of very interesting evidence of you can mitigate weight gain right from the beginning in clinical services. I think it's going to take a whole way of reframing how we look early on at people's bodies as well as their minds. So yeah, we can share the web link to this.
Yeah, we can. Yeah. So I'm going to very briefly just touch on whose job is it anyway, and it falls to primary care, and it's great that we've got community pharmacists, hospital pharmacists, because actually I think you've got a really key role in supporting primary care to do this. You've heard about the risk of smoking, poor diet, social deprivation, loneliness, isolation, being unsupported. And the clock's there to say, often primary care says, oh, we haven't got time to do this, but actually we should be doing this. We should be making every contact count, and there's lots of opportunities for us to do that. So whilst time in individual consultations is restricted, we can have numerous consultations over the year. We can be proactive. It is in the quality and outcomes framework, which you need to respond to. We have the resources to enable us to do this. So there's social prescribing, thinking about allotments and exercise programs, the support for smoking cessation, and we know from the Scimitar programme that supporting people with severe mental illness to stop smoking, you can recruit to a trial and people want to stop. And we've got the HEAL document, and we've got Helen Lester's Don't Just Screen, Intervene document. So we have got the resources there to help people, and to, I suppose I'm going to now show what Mary's, what good can look like, and what Mary is like now, and primary care has a really important role to play in that.
This is about 4 years ago. Mary to reinforce that she can shop. And I suppose the dilemma we have is, Mary's on clozapine. It's extremely well managed. We had to fight initially about the doses. So 900 milligrams, and Mary could hardly stand. She was drooling. And the psychiatrist was keen that we should try reducing it. But the nurse who was leading Mary's care said, I don't know why you're doing this. She's fine. So we had a long discussion, and eventually, several months later, Mary reduced by 25 milligrams, 900 milligrams down by 25. The drooling stopped. I mean, I have no idea why that should happen. This audience may understand it. I didn't understand it. But the impact was that Mary could go shopping more easily. She could actually and she was a little bit more alert. So that let her have a slightly different life. And we reinforced that. She now takes 200 milligrams a day. Now, had she not had that 25 milligram reduction, so part of Mary's, she's clearly well engaged, she's well supported, and she's connected with family. And she is on the right medicine. I've been told don't ever think of stopping clozapine, and I wouldn't dream of it. But trying to titrate it to the right dosage has been a huge challenge, because it has a lot of, obviously it has a huge amount of adverse effects that we have to manage.
There's a question from Matthew at Tees Esken Weir Valleys. Do they ever do clozapine levels at any point?
Yeah, I mean, more recently that has been done. Mary's also had epilepsy recently, and obviously there's a concern that this could have been related to clozapine. But in fact, the clozapine levels have been okay. I mean, just slightly lower than therapeutic ideal. So that was fine. Her psychosis hasn't shown a sniff for years and years. I mean, it's extraordinary, really. Thankfully, the epilepsy is not due to anything other than the brain injury she probably suffered at birth, actually. But that's a really difficult condition for Mary to have on top of the long-standing mental illness.
Thanks, David. I mean, thank you for sharing that, because I think it puts all the science, all the graphs and the statistics into perspective when we talk about a real person. So I'm going to go into breakout rooms. I'm going to adjust the timetable slightly because I'm running over. So we're going to breakout rooms. I think we're going to have 3 breakout rooms for about 12 minutes to think about what the problems are. We've heard about the problems, but it's really about what the problems are in your workplace, in your context, and think about what the barriers are to good care, but then think about how can we improve the prescribing, monitoring, supporting people on antipsychotics. So Deborah, I think, is going to put us into groups, and if we can reconvene at about 11:33 into the big group, if you can nominate one person in your group to feedback, and we want to feedback a key point, if that's okay. So if you could agree as a group to feedback one key point, and then we'll have a little break before we go on to the second breakout room. Okay. Hello everybody. I think I might be back. Thank you. So very quickly, group present a key point about their problems as they see it in their workplace, and then the key point about how to facilitate and improve better care. So we didn't name the groups. So somebody shout out who was the rapporteur from a group, please.
Shall I go first?
Lovely, thank you, Matt.
Then I can remember.
So we talked about working clozapine clinics and some of the difficulties that patients bring to that, and some of the rigidity in their thinking, and some difficulties engaging with people at times, be that because of their cognition ability or kind of belief structure, psychosis wise and things, and the need to actually just sound like a bit of a broken record, just to keep asking the same questions and persisting, because you can make improvements over time, you can wear them down. Yeah, that was one strategy. We talked a bit about some of our medics and how they have very kind of preferred options. Like some of mine particularly like olanzapine and don't rate aripiprazole at all for psychosis, and how that's contradictory to the evidence that you see in literature, and then kind of how we might go about challenging some of that belief. And then one of the things that we've been doing recently in the area is, as specialists, pharmacists working into community mental health teams, is helping draw queries from primary care and PCN colleagues, to help challenge kind of the professional respect that we have for long-term prescriptions. Like, yes, it might have been appropriate 20 years ago, but is it still? And actually ask questions about how the appropriateness of medications long-term, the doses and things like that, and to provide a bit more specialist advice to primary care. I think that summarised everything. Apologies if I missed something out.
Yeah, and just throwing in, we talked about terminology and antipsychotics. Perhaps they shouldn't be called antipsychotics because they don't stop psychosis, and so we had a bit of a discussion about the importance of labelling. Brill, thank you. So somebody from Group 2, who was the rapporteur, who'd like to shout out? Anybody?
I know that we didn't identify one for our group, so I can just comment quickly if that's okay. We discussed a lot around we discussed the primary problem with patients presenting to inpatient wards, and we're just trying to get patients well enough to discharge them, basically. So we're not utilising kind of social activities in there. So patients maybe aren't having a very enjoyable experience. There's no walking groups at the minute because of COVID, things like this. And when they are being discharged, there's that barrier between the primary care, the GPs, and the community mental health teams. So I commented that at the minute I'm working in community mental health teams in Northwest London, and actually we are doing good work in trying to bridge that gap. So we do have people who have been put into positions to try and facilitate communication between GP and community mental health. But like you said before, there's still issues with the implementation of interventions. So we're identifying patients, but it's still deciding, there's not much on how to actually interventions in general, there isn't a lot with that at the minute. So that's definitely something that could be worked on.
Thank you. And the last group.
I can feedback, that's fine.
Thanks, Tom.
Had some really good discussion within our group. There's a couple of, I guess, problems and things that we focused on, really. One was around communication with patients. This was based on a piece of research that Jennifer Southern's doing, or has done. I guess the problem is, do we actually listen to our patients as well as we think we might be? And there's a big case really for better reflective practice, to kind of reflect back on our interviewing of patients and understanding the problems that they're experiencing. A very simple thing, I think, a very simple intervention that could be developed around that to support with that. The second issue that we discussed was a slightly bigger problem, I think, which is about kind of integrated care and working at that kind of interface, and the horrendous kind of experience that patients probably have in trying to navigate the complexity of systems, and particularly when it's kind of crossing physical and mental health kind of boundaries. Mina, I think, I'd like to say an integration champion, I think, and is probably doing a lot of work around this. But I guess it's having people like that within the kind of context, local context, to support with that. it always seems to be down to kind of personal endeavour as well to generate these relationships and things and connections between services. So I think we maybe could do that a little bit better and learn key lessons and know what best practice kind of looks like around that as well.
Fantastic, thank you. I'm going to mention, just before we have a 5-minute break for people to go and get a drink, the Closing the Gap Network. You may have heard of this. It's funded by UKRI, led by Simon Gilbody in York, and it's a network. And can you see the slide?
Yep.
Yeah, great. It's a network where we're focusing on physical health and reducing physical health inequalities for people with SNI. We're in our 3rd year. We've got a primary care special interest group, which you may want to join. There's also an oral health group that David and I are in. So if people do want to join the special interest group, have a look on the website, email myself or Caroline Mitchell, have a look at the resources. There's something called the research sofa, where people sit on their sofa, particularly during COVID, and chat about the research they're doing. And it'd be great to have some pharmacy input into that. Okay, so we're going to have a break for 5 minutes. Can I ask you to come back at 11:46? Deb, would you put us all into our groups? And I'm just going to, if I can, move forward. So think about the key research priorities. And then if you've got time to think beyond that, which funding stream, who do you need to collaborate? But particularly for individuals, think about what's your action. What are you going to take away from today's workshop? You know, have you made some collaborations? Have you picked up a name that you think, I'd really like to work with that person? Says feedback for each question. If we've got time to do that, that's fine. But particularly feeding back on what you think the next research questions are. Okay, so we're going to have a break. Actually, come back in 5 minutes. So that's 11:47. So please go make yourselves a cuppa and just stretch your legs. I'd like to feedback. I'm trying to upload my slide with the questions on. So did anybody, would a group like to feedback on a key research priority that they identified?
I don't mind doing that if that's agreeable for the group, since I sort of fancy myself as a researcher. I think that's not an unreasonable thing to do. David spoke very helpfully to us. David, who's now twice on my screen, which is nice. Now he's gone. Now he's back. Spoke very helpfully about getting these sort of tailored, personalized activity promotion interventions into early intervention teams. And he spoke about a pilot that had been done in Australia, and I think maybe had been replicated here in England once. But I wondered if a full-scale trial with full-on health economic evaluation of such thing, because we've already identified that the key time is the first 12 weeks, and obviously it's the most difficult time because people can be very distressed and might benefit from some sedation, but still one could establish helpful patterns. So I thought that was a good idea. And then Chinny came out with a late thing about wellbeing passports, which I think is something that really could help improve the communication between primary and secondary care. And so that sounds like a relatively inexpensive and small scale thing to look at, which might be of some benefit. So those were the two thoughts that we had. I thought the first one should be an HTA, serious piece of HTA work.
Thank you. Yeah, Chinny, do you want to talk about wellbeing passports? Because that's something I'm not familiar with. I don't know if other people are. Is Chinny there?
Yeah, hi. I remember going to a talk by GPT, James Lee. This is quite a few years back in a CMHP conference, and he mentioned about having a well-being passport. It's like a booklet where the patient carries with them from when they're being admitted in the hospital, secondary care, back to the primary care. So they have a list of all the medications and the patient's weights, all the monitoring parameters. So the patient, when the patient goes out into the primary care team can continue this booklet, and they could see if there's any changes in the patient's physical health, has it gone down, gone better? Yeah, so that's the point of the wellbeing passport.
I suppose it's a bit like maternity notes, isn't it, where women keep hold of their own notes. Yeah, yeah, that's an HSNDR really, isn't it? That would be a really good study. Does having a wellbeing passport increase patient autonomy, I guess, and self-efficacy? Fab. Anything else from the group that David Kessler's just presented back? Can we move on to the next group? Perhaps the group I was in. I think it was Bindo was going to present. Or Clara, do either of you want to talk to that? I don't know if you're here. I think we've lost a few people in coming back to the big group. Is Clara here or Bindo? So it doesn't look like it looking at my screen. So I'll just briefly mention that we talked about the possibility of a trial around antioxidants for the treatment of psychosis. And apparently there's a Cochrane review that Binda mentioned. I was going to ask her to send that round to folk. So apparently there is some evidence, and this is, I'm talking secondhand, there is some evidence for antioxidants in some neurological conditions and some psychiatric conditions, such as ascorbic acid. And so we had quite a long discussion about that. Is there anybody else from the group? Clara, you're here. Do you want to add to that? Because I think you had quite a lot of knowledge on this.
Yeah, just to add that, yeah, I think the confusion as well that they said because they're nutritional supplements, they are not as regulated as medicines, and actually you can get supplements as good as medicines. You just need to make sure the manufacturer got good manufacturing practice, the GMP, and it's a number of nutritional companies in the UK that they comply with that, and you can find that through the MHRA. And also talking about research, to mention about that things like that, nutritional supplements, the funding, it will be quite difficult because normally the funding for drugs is funded by drug companies and they have a completely different budget. And also that you cannot really patent a supplement. So that is not going to be, looked, who is going to fund that at the end of it. A company is not going to make money out of it. So that's the reality. I think that's all what we talk about really, and that would be quite nice to have research into alternatives to drugs like antioxidants. That was quite interesting.
David Shire's hand up.
On the similar sort of theme, can I just alert people to one of the Frontier articles in our little collection was, I think it was called Drugs and Bugs, but essentially it was about the gut microbiome. And what I hadn't realized was that antipsychotics act like antibiotics. They're actually antimicrobial. So if you think that you're on antipsychotics for very many, many years, and then think how that might then give you a sort of gut dysbiosis, I think this is sort of like very interesting new research. And I know there are crossovers with gut microbiome in terms of very early onset, predicting anxiety, depression in children in future life. And so I just think that's an area of nutrition to watch out for. And maybe some novel treatments that will emerge. So it's like new sciences. Yeah. Was anyone else aware that antipsychotics act as antimicrobial agents? Or have I dreamt this up?
No, obviously need to have a look at the full list of papers that your editorial accompanied.
Yeah, it's a very nice article, actually. It's good.
Really interesting.
There's tons and tons of stuff coming out about the microbiome, but I haven't really got my head into it. Sorry.
Trying to eat more sauerkraut at the moment.
Yeah.
Certainly, if you go to any artisan markets, you can find sauerkraut, can't you? I'm afraid I can't get into it. Any other comments on this sort of antioxidants? So there should be one group who might want to feedback their ideas for research questions.
Yeah, we were talking about we'd been talking about primary care, secondary care in the previous group session. So we were talking about what potential research there was there, and just starting with the sort of small scale is Mina is already working on a project to help transfer patients who are stable from having depots prescribed and administered in secondary care services to primary care, where they receive the rest of their sort of health needs. That is their locality have reached a decision that that's what's going to do across primary and secondary care. And it's about how they were going to do that, but also then how do you measure how successful that is? And Saeed helpfully suggested that perhaps a patient satisfaction survey would be a relatively simplistic way for Mina to be able to measure how effective that was, and obviously capturing the patient satisfaction is what is all important in making that switch, because that was the point of them making the switch, was to try and improve care and access to care for the patients and keep their care all as one for people who were stable. So we were just looking at something that was easy, didn't need a massive amount of funding or a massive amount of work, because Mina and I are both full-time clinicians, so we aren't in the position to start doing a full-scale research project. So we were looking at things that we could do that fitted in within practice that we already have. Does that cover it?
Yeah, no, that's really helpful. Yeah, because I think you're absolutely right that people, I mean, certainly in Manchester, people get discharged very early back to primary care and have their depots, but there isn't a very good process around that. And, you know, we delegate to healthcare assistants to do this. And then people are supposed to have their QOF checks, their physical health checks as well, but actually bring it all together and seeing if the patients are happy with it is really important. And I guess it fits in with this wellbeing passport, doesn't it? You know, maybe that's a way of giving the patient a bit more autonomy. They're holding on to their records about their drugs, but also about their physical health, and being able to use that. So yeah, that's really interesting. And certainly it would be something that, I don't know if you've thought about, the CTG, the Closing the Gap network, does have small funds to support things like this. So it might be worth you looking to see if there's anything available at the moment. Okay, that's helpful. Does anybody else, David's put something in the chat about an article.
One, and then Joseph's programme as well I put in.
Fab, thank you. Any other research questions or priorities that people want to mention? I guess I'd like everybody who's participated today to think about an action that they're going to take away from today back to their workplace. And that action might be about clinical work or policy, or about research and about collaborating across primary, secondary, community care and pharmacy. I'm going to just mention oral health again. So David, I've got this slide, but if you've got a slide that you can put up quickly. Yeah, well, I can see it.
Weird is I can't see it myself. And anyhow, I can't.
Can other people see it? A yellow, no health without oral health.
Okay.
Yeah, it looks like people can see it, David.
Yeah.
Unfortunately, I can't, so I can't scroll the blooming thing. But this was a consensus group under Closing the Gap initiative, which came up with. We talked as a group about the problems, and then we thought, well, we'll come up with some outrageous 5-year targets, policy practice. A lot of it's about, you know, basic common sense things, really, about having access to dentistry. That's a real issue, but also how this population do struggle. So the idea of putting the consensus together is because there is so little evidence and so little policy directive. We thought it was a good idea to try and create some momentum. So this is an initiative really where we're opening our arms really for people to be interested through the Closing the Gap initiative. I don't think we've identified mental health pharmacists. Well, Peter Pratt, we have Peter Pratt, of course, in the group, who's the NHS England pharmacist. But just really to flag up this area as a sort of an opportunity for research and practice, and that if you're interested in finding out more about this, I can, very happy to be contacted, and I can do a bit better and do more than just scroll this. Well, I can't scroll this thing. Is that helpful, Carolyn?
Yeah, if we go back to my slide then, if you stop showing yours, mine should still be there, hopefully, because that does, can you do that? Oh, mine isn't there anymore. Oh, God. I honestly think that the technology is going to beat me. Right, I'm sorry about this. We're just trying to get this up again. It looks like it's loading.
I mean, the medicines issue here is I suppose, about dry mouth and grinding of teeth, as adverse effects of antipsychotics, and the fact that these drugs are being prescribed. And we know this is a very high-risk population who struggle.
Yeah, I mean, I think that's right. And as I mentioned earlier, it's our healthcare assistant who does the sort of QOF physical checks, but doesn't mention oral health, although has started to, because I've sort of passed the message on. But it's not in the tick box, and often in primary care, if things aren't in the tick box for targets, then it doesn't get done. So yeah, if we can publicise.
So no physical health without oral health.
Yeah. So can you see the slide? She says.
Yeah.
Sorry.
No, I think we can see the slide. Yeah.
Fantastic. And so, yeah, this just sort of summarises our thinking and our chats around problems about oral health, how to promote good oral health, about the importance of information sharing, and really, as David said, having a dentist who is completely aware of the dental concerns of people with SMI, and perhaps using fluoride paints. And so we've developed a number of targets. And David, when's this going to be released?
We're just in the final stages trying to get a web platform and stuff like that. So it's imminent, a couple of weeks probably.
So it will go on the Closing the Gap website.
Yeah. And we're also hoping we can have a dissemination. We're hoping for a successful bid for a dissemination project over the next 10 months or so we can talk about it. But I mean, we don't need to have a formal dissemination project. I'm very happy to to talk to anyone that's interested really and share this.
And certainly if we can share it amongst the pharmacy community, that would be fantastic, because people come into the pharmacy, whereas perhaps they're not coming into practices as much, or decline their physical health check, but they're coming into pharmacies. They may be buying their toothbrushes from you, and so there is the opportunity, isn't there, of community pharmacies particularly having a role to play. Okay.
A novel idea of including a high fluoride toothpaste and a toothbrush with every time a prescription was picked up. But I don't think that will get funded somehow.
I don't think commissioning groups would fund that, would they? What a shame. That's a really, really neat idea. Is there a research question in there?
Well, it's how you get behaviour change, isn't it?
Yeah.
And practitioners, I think, too, giving a simple alert to practitioners.
Yeah. I'm going to write something down on that. That's a really lovely idea. Okay. Want to finish on time because everybody's really busy. So thank you very much, everybody, for participating. We will be sending out a thank you email, some links to the information that we talked about. I think we can probably send the slide sets out as well. We've recorded this webinar. It's going to be uploaded onto the School for Primary Care Research website and available. Our emails are there if you want to contact us. And I think that's probably it. So hopefully you'll take something away. Oh, yeah, I know we'll also send out a Survey Monkey for you to tell us how good or rubbish it was, because we've got at least 2 other workshops and we can make changes depending on your inputs. Do keep an eye on the School for Primary Care Research website because more workshops are coming up. So thank you, everybody. It's 12:19, so I'm finishing a minute earlier than we said we would. Thank you very much, everybody.
Thank you.
Thank you.
Bye-bye. Thanks for attending. Bye-bye.
Bye. Thanks.